know now that healthcare providers are at least at a 2 to 3-fold higher risk of being infected by COVID. In the US, according to the CDC, close to 1,000 healthcare providers have died or have been seriously injured, and close to 500,000 have been infected. So these numbers are not inconsequential by any means, and so that risk continues to be an issue. Hello there. My name is Dr. Paul Barish. I'm a clinical professor at Wayne State University and a faculty at Jefferson College of Population Health. I'm delighted to be with you today to talk about our upcoming paper in the Mayo Clinic Proceedings entitled COVID-19 and Medical Education, Risks, Benefits, and Institutional Obligations During a Global Pandemic. We are very excited about this paper because it really culminates of 10 months of thinking very deeply about the extraordinary challenges that above and beyond the clinical challenges that we've all been struggling with in the US, but the challenges that medical educators at all levels, undergraduate, graduate, and postgraduate levels have been struggling with, how best to find the right medium and a safe way to deliver medical education, doing it in a way that's safe for patients, doing it in a way that's safe for the trainees, either medical students or residents or fellows, as well as doing it in a way that's safe for the organization. One of the most unusual aspects, I think, of our paper is introducing an innovative concept around a risk-benefits perspective for evaluating medical education and introducing a novel decision-making approach for how to justify on the fly, if you will, as things evolve, to make it possible to make more meaningful activities for students, residents, and fellows that while they carry a high risk, equally, they also demonstrably carry a high benefit. By being very explicit about the benefits and the risk, we feel that the conversation is much more thoughtful and meaningful, as opposed to some of the early instinctive responses, which more or less shut down all exposure to COVID patients for medical students and limited resident exposure as well. So we introduced a framework of 4 considerations, and I want to briefly walk you through that framework. The first framework introduces a concept that comes from nuclear engineering, ALERA, and the ALERA concept really speaks to the fact that all radiation, of course, has risk. Equally, all exposure to COVID has risk. And so the question really is not possible, can we do this without any risk? It will have risk. The question is that risk justified? And the ALERA principle essentially argues, since all radiation exposure, or for the sake of the matter, all COVID exposure is dangerous, if we could provide a framework that actually assessed the amount of risk for the student or learner, then we could justify how to mitigate that risk so that we understand that if you will, the informed consumption of risk, the informed assumption of risk by being exposed to COVID patients is worth it, if you will. Now, what the ALERA principle also introduces is the fact that risk is a property of the time you're exposed, the distance, your exposure, and how much shielding you have. Very similar to the time around COVID patients. We know 10 to 15 minutes usually is the amount of time in which you're at risk, either taking care of patients or at a restaurant. Secondly is the distance you're from the patient, and finally is the amount of protection you have through the use of PPE and things that might protect you that way. The second principle, which we've introduced, is the principle of as high as conceivably achievable. That is to say, is it possible to actually educate students, residents, and fellows in a manner that reduces the risk, or is this a Sisyphean effort, if you will? And it's clear that being very explicit about which parts of clinical encounters are in fact beneficial, while risky, whereas other aspects that are less beneficial but are risky, and so we can separate the two. For example, there are elements of education and training that should not pose a higher risk if you're properly protected versus, for example, being in the operating room where there's aerosol-inducing procedures. And since you're not directly participating in the procedure, the benefit that you're going to get from it might be very limited, as opposed to observing a procedure pre-COVID or at a reasonable distance. So that's the second one. The third principle, of course, relates to the broader perspective of consent of risk. Are students and trainees given the opportunity to understand the risk of being exposed to COVID patients? And if so, how can we help make sure that that informed consent is clear, while making it very clear that in return for assuming that risk, they have educational benefits, crisis management benefits, as well as clear leadership opportunities. We've learned from previous pandemics, either Ebola or SARS, that in fact there are great benefits for trainees as long as we can balance those risks with the benefits. To do this meaningfully means that we at all levels, that means deans, that means program directors, that means hospital leaders, have to have a regular conversation about which activities do offer more benefit versus the risk, whereas others that don't. How best can we use, for example, alternative asynchronous, either in time or in place, for example, telemedicine? It's clear that as the pandemic proceeds, now that we're into the 8th or 9th month, originally the solutions, which were itinerant solutions for a month or two, need to be thought about in a broad perspective, which is what happens if this goes on for several years and how do we deal with this? And so we've laid out some very clear recommendations. For example, limiting the number of trainees in the room. For example, making sure that they all have proper PPE. They're trained in proper PPE, not just by lectures, but using simulation to understand what are vital skill sets to protect yourself. For example, putting on and taking off or donning and doffing PPE turns out to be extraordinarily high risk. So it's very clear now that we've moved into a more of a steady state, if you will, as it relates to this pandemic will be here, is that to apply this framework, we need to, number one, be very transparent with our learners about what your benefits are and what are your risks. Number two, daily and regularly monitoring the balance of risk versus benefits using the ALERA principle. Number three, making sure that there's ongoing training in the use of PPE, as well as simulating what happens when you're infected or exposed to an infected person, reinforcing the primary principles of infectious management, as well as making sure that we document what is the risk to the learner so that if they do get infected, we have a mechanism both to take care of them, as well as, of course, to ensure that they receive care, and particularly as medical students who don't necessarily have the same type of health insurance as residents and fellows, to make sure that they have adequate healthcare coverage for that period. And finally, of course, that we understand that the balance of the duty to treat and the consent to take care of patients is a foundational principle of the relationship between healthcare providers, learners who are about to become physicians, and the patient. Finally, of course, that we just remember that while it's easy to assume that if we remove these trainees, they won't get infected, but equally, there'll be lots and lots of lost opportunities. And so in order to ensure that we have value-added roles for students and residents, we make sure that these things are very explicit. So to sum this up, we believe that this paper adds an important aspect to the conversation about how do we justify the exposure of learners, medical students, residents, fellows, as well as other non-physician learners to the COVID risk by making it very transparent, by making a very clear dynamic risk assessment, and being very clear about how these assignments to students and learners ultimately add value to the patient, add value to the learner, and also add value to society. So thank you for listening, and I look forward to comments to our paper as we follow through with further studies to collect more data about how this experience has shaped and influenced the trajectory of undergraduate and graduate learners. Thank you.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.